My name is Ron Fitzwater. I'm the CEO of the Missouri Pharmacy Association. Thank you very much for being here. We have made a commitment working with the state and with our task force that we will do what we can to get the message out to pharmacists across the state of Missouri. It's a very critical project, as you probably have seen over the last year. Governor Greitens, Director of Department of Health and Senior Services, Dr. Randall Williams, have been very engaged, and they have been very open about bringing pharmacists into this entire opioid crisis. As we met and talked with the task force and met with Dr. Williams, his goal is to have this product available in 100% of pharmacies in the state of Missouri. Pressure's on us, but I think our board has jumped on, and I think it's going to be a great project for our state as we talk about the opioid crisis. The prescription drug monitoring program, there's no silver bullet that's going to solve the problem, but each of these individual pieces give us one more tool to try to address the problem. Hopefully we can get folks before they get to the point where they need this product, but if we can't, we want to make sure that the resources are available in the community. So with that, I'll turn it over to our speakers for tonight.
Okay. Thanks everybody for being here. I'm Amy T. Meyer. I am an employee here at the College of Pharmacy, and you'll hear a lot of the meat of the presentation from Nicole Gaddis and then Kelly Gable, who's our wonderful partner from SIUE. We don't have any disclosures to reveal or anything like that. No funding by any of the Naloxone products. Just wanted to thank the people who supported this program. So obviously, Missouri Pharmacy Association, the College of Pharmacy, and then also the Missouri Board of Pharmacy. For Nicole and Kelly and I, the funding for the larger grant comes from SAMHSA, and they put out a statement saying that if you come to us with a reasonable proposal, we will fund you, and that was for any state. So it was for states to respond to the opioid crisis in the country. That money came through SAMHSA, the Substance Abuse and Mental Health Services Administration. These are the different areas that they're focusing on. They got essentially $10 million each year for 2 years to focus on this. So a lot of money trying to get very quick results and get things moving forward very quickly. So they are focusing on areas of prevention, treatment, recovery, and then sustainability and community impact. We fall into the treatment portion, and then again, there's lots of different people working on each one of these different bullets. So it's a very broad, very wide-reaching grant that you're going to see. You'll see different things with. At the end of this activity, you should be able to describe the process to provide direct consumer access to naloxone, and including the Missouri Standing Order. Describe the role of pharmacy personnel in opioid overdose management, identify risk factors for opioid overdose and symptoms of an overdose, and then discuss the rescue therapy mechanisms of action, appropriate use, and available delivery systems, and then identify ways to engage patients in discussion, which is probably the piece that many of us would feel most uncomfortable with at this point, that we probably feel a little unsure how to handle. I don't know, we have any technicians in the room? We also have this approved for technicians. So hopefully in some of our other presentations, we'll get some technicians as well. But we're going to go through our different questions right now. And as we go through the presentation, you should be able to ascertain the answers to these. So we'll just go through them really quickly. So one of these is true. So be thinking about that. See whether or not you know whether or not which one of these is actually true. Again, we'll review all of these at the end. And then true or false. Do all these components need to be included for every person dispensed or sold naloxone? Looking at risk factors, so it's really important to know who we should be advising or who we should be recommending get naloxone when they're at our pharmacy counter. So one of these is not a risk factor, the rest are. And then looking at medication delivery systems. So there's a couple different ways that this medication can be delivered. You're probably aware of a few of them. We want to make sure that you're aware of the differences, how they fit in with the standing order, and how they are administered. And then when we're talking about patients, this one is hopefully pretty obvious. If it's not, it should really be obvious by the end. This is getting to the stigma that we are hearing that people encounter when they are dealing with this issue and when they are going to the pharmacy, unfortunately. And so we really want to make sure that we are talking about what we're hearing and what's going on, and talk about how we really need to be discussing this issue and how we refer to it. So your first little piece of active learning, so write down 2 barriers that you would anticipate encountering with regarding to dispensing naloxone in your pharmacy. If you don't have a pharmacy, think about a community pharmacy that you've worked at in the past or a community pharmacist that you know. What are 2 barriers that you anticipate that they would face when dispensing naloxone?
Have we identified some barriers? I think there are quite a few barriers, unfortunately, and hopefully we'll address some of them. Does anybody feel comfortable to share a barrier that they came up with?
Stigma and embarrassment to come and say you want.
Absolutely. For the consumer or patients, embarrassment to come into the pharmacy and ask for it. And on the flip side as well, maybe our own internal biases and stigmas that we carry with us. We all do, right? Good. Yeah. Either one.
People not realizing that they need it or want it, so they don't.
Absolutely. Not realizing that I want it, not really realizing I can come to the pharmacy to get it, and it's that simple.
From a pharmacy perspective, we were thinking just the barrier of having it on stock, and maybe it's so new and just what does that mean?
Oh, what a good one. So do I stock it? If I'm going to hold on to it for a while, is it worth stocking it? Very good. Thank you for saying that. Good. And which product, right? Now that we have so many different naloxone products, which one? Excellent. These are very good barriers.
If you potentially dispense it, is that more of like a license to go ahead and run up to the edge of the cliff and go ahead and overdose?
Good. Thank you for saying that. Yep. And that is, I'm so glad you said that. That brings us right into the next slide, actually. Okay. But before we talk about the elephant in the room, let me just introduce myself. My name is Kelly, and it's just been such a joy to work with Amy and Nicole here at St. Louis College of Pharmacy. I come from SIUE. I think more importantly, I bring to the table my clinical experience. I work as a psychiatric pharmacist in St. Louis City at an FQHC. So I get to work a lot with primary care providers and work with folks who are struggling with substance use disorders. And so I really want to address the elephant in the room. So first of all, we can safely identify that we have an overdose crisis that we are facing in the United States. Pharmacists are well positioned to have a huge impact in reducing these overdose deaths, right? Yet, there's still a disconnect. And we need to figure out what that disconnect is and make sure that we're disseminating that knowledge. Part of it is, what are our own internal biases and thoughts? How do you feel about someone who's actively abusing an opioid? How do you feel about someone using heroin, right? How do you feel if your neighbor's using heroin or someone walks into the pharmacy and they're asking for needles? What kind of things are happening in your brain? And how do you respond to that? How do you treat people, right? That's really the elephant in the room, and that's something I hope we can address some of the thoughts that you have, and we can start to change some of those thought processes, because the reality is people are dying, right? And we have the opportunity to save lives. I get a little excited about this stuff. I don't need to spend a lot of time here because I think, again, unless you're living in a bubble, you hear every day on NPR, you hear on whatever news channel you listen to an opioid-related death or something that's come up in the news, right? So I want you to notice any opioid, it's rising. Deaths from any opioid. I also want you to note the other synthetic opioids as well. So we're talking about additional use of fentanyl, and not the fentanyl that you're seeing in your pharmacy, the fentanyl that's derived synthetically on the streets, right? So carfentanil and fentanyl in particular as well. We see a dramatic increase in deaths just from that. Now, if you look here, I want you to take close note to where you work. Do we have a problem in St. Louis City? Yes. The data would say nationwide, we have a problem in St. Louis City, right? Over 80 deaths per 100,000 people. That is over twice the death rate of other parts of Missouri and of the average in the nation. We have a problem in St. Louis City. Absolutely. Unfortunately, St. Louis is a destination place for heroin. So the deaths that we see in our region, over half of them in 2016 were related to fentanyl or fentanyl derivatives inside prescription opioids or abused or heroin. So keep that in mind. And again, I want you to know this is not the fentanyl that they're taking from a pharmacy. It's being synthetically derived on the streets. So just knowing what we're working with here, again, we're going to talk a lot about who's at risk and who's not. Anybody exposed to an opioid is at risk, right? We got to be clear about that. But if you're injecting heroin or snorting heroin, absolutely you are at a risk, right? Now, you may or may not be privy to that information, and that person may or may not come into your pharmacy, but we want to capture everybody. We want to capture folks that are getting their prescription opioids and folks that are also getting needles or asking for needles or using heroin. So why do people use substances? I'm not going to spend a whole lot of time here, but I do want to spend a little bit of time here to talk about the biology of addiction. So, because I think this is again where a lot of stigma comes about. So you tell me, first of all, do you think people use substances because it's their choice? It's kind of that's a bold statement. Is it a choice to use substances? Okay, so it's about the environment and the community, and people sometimes adapt to what they see in their community. Do people choose to use heroin? I'm asking you a loaded question. It's okay. Don't be afraid to speak your mind.
I think a lot of people, the first time they use an opioid, not necessarily, I don't think people jump right to heroin usually.
Okay.
If it's for recreational use, that is a choice.
Okay.
And if it's for a condition that they were being treated for, those people sometimes naively, they became addicted. But I think for recreational use, yes, the first time was a choice, but then after that, I don't think it becomes a choice.
Well said. Well said. I didn't choose to get into a car accident and have chronic back pain, right? And I didn't choose maybe for my primary care provider to give me OxyContin, right? I also didn't choose my genetic makeup and the fact that I have a genetic predisposition for an addiction, right? So I want you to think about what brought someone to the place they're in when they're in your pharmacy asking for naloxone. Why do people use substances? You could argue the very first time anybody uses a substance, whether it's oxycodone or heroin, that is their choice. The very first time, just like you said, right? After that, it becomes less of a choice and it becomes about survival. So people use substances to feel good, and I want to be clear that feeling good may be, I am chronically depressed or I am chronically anxious and I just need to feel alive or better, right? Some people use to feel better, meaning I'm always in pain. I am always in pain, nothing is working, and my drugs, my prescriber's not giving them to me anymore, and heroin's a lot cheaper and accessible, right? To do better, meaning maybe I just need to get out of bed, to go to work, to pay for the bills, and my family, to survive, right? And you could argue that some young people are curious, right? Maybe that's what drives them initially to use a substance. No matter what it is, the first time you use is often a choice for most people. However, after that, our brain takes over, right? So we look at, I'm going to come back to this slide, but go here first, and I love what you said, sir, in that it's about biology, genetics, psychosocial, environment, okay? And some of these we have control over and some of them we do not. 40 to 70% heritable. Addiction is 40 to 70% heritable, and opioid addiction is closer to the end of 60 to 70%, okay? So you can bet we don't choose that part, right? Now, just biology and genetics alone doesn't cut it. What if I'm in a pretty horrible environment? Right? What if I'm in an impoverished area where I can't get other resources? And psychosocial pieces to that, like chronic pain, recent divorce, lost my job, right? So imagine all of those together. Now I want you to go back. I want you to channel what happens when someone takes an opioid. So I want you to think about, we've all had the experience of eating a nice meal. And what happens neurologically when we have a nice meal? When we smoke a cigarette, when we engage in sexual activity, we get a flood, a rush of dopamine, right? It happens to all of us. And our brain says, oh, that was good. I liked it. Do it again, right? So you get about a 50% increase in dopamine response when you eat a nice meal. With cocaine, with opioids, it can be anywhere from 200 to 1,000% increase in dopamine flood, right? Imagine what that feels like. And we think that somebody who has a genetic predisposition for an opioid use disorder already has a deficit of dopamine receptors. So because of that, they have a higher impulse or poor impulse control, and it feels a little bit different when they use for the first time, right? So that explains why you may use an opioid and feel very different than what I feel, right? We're all genetically made a little bit different. So I want you to imagine then I use again, and my dopamine receptors rise and rise and rise, and I get a tolerance. And we all get it, right? We all see tolerance happen with opioids. And then what happens when I stop? The withdrawal happens. What happens to my behaviors psychosocially? What do you see? It's horrible. Doing some things that I wouldn't normally do, right? Like acting really awful at a pharmacy counter, right? Or acting really terrible to my family or to my coworkers, right? So it drops me into a place where my dopamine receptor levels drop well below where they were, and you bet I've got intense cravings, and I'm not myself, right? It's a horrible place to be. And what am I gonna do? Anything I can to survive. And what does that mean? My next fix, right? And that is the circle of addiction. So I want you to be thinking about that, because I think sometimes we lose sight when someone comes into our pharmacy and we are tired and we are frustrated, and we lose sight of the fact that that is a human being in front of us who is struggling, right? And yes, maybe they're giving us a hard time, but they are struggling. And we can do something to help them. Okay. So here, I want you to look at chronic conditions that we may treat or you may work with, and I want you to see the comparison to substance use disorders. So you look at the recovery relapse. We're looking at about 50% for addiction, and look at diabetes, and look at hypertension. So yes, my blood pressure fluctuates, right? It goes down, it goes up. I stop my medicine, go back on it. My diet's poor, and then it's good. So I relapse, I recover, I relapse, I recover, and we see the same thing with addiction. I love to show this to people, especially the lay public, to show them and give them hope, right? Just like any other chronic condition, people have the power to recover. And we can be a part of that change as well. As pharmacists, we can be a part of sharing that knowledge that people get well, people recover, and they do well when they do. All right, so what is this about today? We're here, obviously part of the STR grant. And what we want to talk about is prevention, treatment, harm reduction. So we're going to talk about harm reduction today. Naloxone access and easier access is all about harm reduction, reducing harm. You are going to see a lot going on in the city of St. Louis and also across our state with MAT. MAT is exactly what you think it is. Medication-assisted treatment. It's methadone, it's buprenorphine, right? So you're going to see a lot more exposure to buprenorphine as well. In fact, I'm really excited about this. We had one buprenorphine prescriber at my clinic for years, and now we're going to have almost 5, I think. Just as part of, I think, the grant that we've been a part of has gotten out there, people feel the need to want to help. They want to do something different. So you're going to start to see more buprenorphine prescriptions, and maybe not so much methadone, but buprenorphine has really been the push for this type of treatment. Other forms of harm reduction that we'll talk about also include syringe access. So what is naloxone? Naloxone's pretty simple. It's actually a really simple drug. For the students in the room, how does it differ from oxycodone? So naloxone is a competitive opioid antagonist. And so it's an antagonist at all receptors, mu, delta, kappa, but we don't care about anything else other than it reverses an opioid overdose. That's what it does, right? It's an opioid antagonist. No matter the opioid, it reverses an overdose. That's what we care about. How does it work? It has a stronger affinity to the opioid receptors. I love this diagram. And the duration of action is 30 to 90 minutes. And this is important for lots of reasons. When we educate people, if someone gives someone naloxone and they've taken a long-acting opioid, you bet they could go back into an overdose, right? So imagine if they took methadone along with a couple other things, right? So we want to make sure that somebody doesn't get naloxone and then go about their day, right? They're not going to be feeling too great. But we want to make sure that they get medical attention after they get naloxone. Okay. Ask the audience, will naloxone treat an overdose from alcohol? What do you think? What about Adderall? What does an overdose of Adderall look like? Cardiac arrest. What about cannabis? Do you think that's heroin or cocaine in the right corner? You know, interestingly enough, I didn't put this picture in here, but I want to tell you that that could easily be heroin as well. I'm assuming it's cocaine too, and people will often taste it to tell, but I will tell you that heroin is also white. It's brown, depending on where it comes from, or it's white. So know that too. It can be deceiving, and it's often mixed with a lot of other things too, right? So you're right, guys. Naloxone does not affect any of these. So if I used a barbiturate, alcohol, and an opioid, and you give me naloxone and I'm still not doing so hot, I still need emergency medical attention because I've overdosed with other substances too, right? Or if you give me naloxone and I've taken these other substances, this isn't going to cut it. So we want to be clear, we're talking about opioid overdose only. Okay. Ooh, how quickly can you name the opioids? Just shout some out. Any opioid you can think of. Hydrocodone, oxycodone, oxymorphone, morphine, fentanyl. Good. Buprenorphine. Okay, how about some street names? What are people calling these drugs on the street? Oxys, perks. There's a lot of names, guys. These are just a few. But just know that a lot of them derive from heroin. So there's quite a few terms that have been used for heroin for a long time, like dope, junk, smack. And you're going to see some of those terms also now used for prescription opioids. And also note that you get this, the manufacturer on the drug or the letters and numbers on the drug become the street name as well. So when that changes, that also changes on the street. Some of these you can find in rap lyrics. It's popular, okay? All right, so let's talk about who should be getting naloxone. I think we've set the stage here, but I want to go over 3 separate cases, and I want you to be thinking about each of these as very different experiences. So let's talk about Tina first, a 34-year-old female presenting to the emergency department with an abscess on her arm. She has chronic back pain from a car accident. She can't get control of her pain. She was taking oxy, cyclobenzaprine, and alprazolam, and after she tested positive for heroin, she was dropped by her PCP. That's not that uncommon, right? Okay? She's using heroin daily just to get control of her pain. Does Tina need to get naloxone? Why? Good. Yeah, that's all you need to say. She's using heroin. Anybody who is using heroin needs naloxone. All right? People know it on the street, but not everybody has access to it yet. You can bet if someone is injecting heroin, they have heard of naloxone, but they may not have access to it. All right? That's part of what this is about, is getting access to it. Tina needs naloxone. She needs to get it from the ER, but she may not. She needs to be able to walk into the pharmacy and get it, but that may not happen. And these are those barriers, right? Okay, I'm going to skip through this, but this is just that reminder of what opioid use disorder looks like. There are lots of things that could be happening for someone, and they only need 2 on this list. Persistence, I was looking for tolerance withdrawal. That's it, right? Along with problematic pattern of opioid use that leads to those. So we'll leave that for you to look at in your slide. But know that with any substance use disorder, if you go to the DSM-5, with alcohol use disorder, you're going to see the same thing with alcohol. With nicotine use disorder, you're going to see the same thing with nicotine.
On the previous case, when you say does she need naloxone, you just mean on hand?
Oh, good. I like that. Thank you for clarifying. Yes, she needs to have it on hand, right? She only needs it if she overdoses, right? Anybody who gets an opioid only needs it if they overdose, and we hope that doesn't happen. But yeah, no, she doesn't need it to take routinely. Thank you for clarifying that. How about Bobby? Bobby is an interesting situation. He's a 53-year-old male diagnosed with prostate cancer. He's on a chemotherapy regimen, and he also takes oxycodone that's prescribed for him, 80 milligrams a day plus Oxy 10 for breakthrough pain, and his wife found him unresponsive on the couch. Does Bobby need naloxone? Handy. Yes. Does Bobby have an opioid use disorder? Probably not. We don't know because we don't know the details, but the odds are no, he doesn't, right? He's probably taking this exactly how he's supposed to, right? Yet he's still at risk, which goes back to anyone who has exposure to an opioid is at risk for a potential overdose, right? So Bobby's not the typical case we would think of. And I think oftentimes we think naloxone and we think heroin, but it's not just about heroin, right? Okay. So these are the signs of intoxication versus withdrawal. Do people die from opioid withdrawal? They do not. People feel like they are dying when they are going through opioid withdrawal, but they are not going to die, right? And that's kind of the clinical controversy with treating opioid withdrawal. Can you die from opioid overdose? Obviously, yes, that's why we're here, right? Be very clear, though, the difference between opioid intoxication and overdose, right? You do not want someone to get naloxone if they are intoxicated. That doesn't make any sense, right? So what do you think the difference between intoxication and overdose is? Good. Respiratory rate is lower. They're not responding. We're going to get to this later, but blue fingertips, absolutely. Not breathing at all. So we're going beyond what we see with this opioid intoxication to an overdose, right? Okay. You ready for Lisa? Lisa's my favorite one. Lisa is a 50-year-old female diagnosed with Crohn's disease, fibromyalgia, GAD, back pain, and sleep apnea. And she's also taking duloxetine, quetiapine, diazepam. Oh, we see problems here already, right? Hydrocodone. Oh, there's a Z-hypnotic. What do we think about Lisa? Oh, wait, she sees 3 different specialists. And guess what? She still has pain. What do we think about Lisa? So I think that, clearly she needs naloxone handy. But I want you to tell me what you really think about Lisa, and what do we think and feel about why no one ever talks to her about naloxone? Yeah, beautiful, because she's seen 3 different people and you, right? And no one gets the full picture, so we may not know. Again, the value of somebody going to the same pharmacy every time, right? What else do we think? And this is a pretty standard patient that I would see, by the way. Yes. So she doesn't meet that criteria in a lot of people's heads, but I tell you what, she is a really high risk. Why is she a high risk? So I want to tell you 2 things here. She's on a benzo and an opioid, and she has sleep apnea, right? Those things together put her at an incredibly high risk. So I want you to think about that. Anybody that comes into your pharmacy, if they are on an opioid and a benzo, that is problematic. The CDC guidelines now tell us we should not be using those 2 together. So be really clear that that puts somebody at a very high risk. Plus the fact that she has sleep apnea. Is sleep apnea common? Yes. It's very common and undiagnosed. Okay. Who is eligible to receive naloxone? Here are all the eligible candidates. We don't have to go through all of this. But I do want you to know it was super exciting to get an email today that Walgreens made an announcement that they will now talk to everyone who is getting an opioid dose over 50 morphine milligram equivalents a day. I don't know how they're going to do this, but they're going to do it. And I love that they put it out there. So Walgreens is on the bandwagon, so we need to make sure everyone is. But I want to be really clear, from my perspective, anybody that's taking an opioid, we should be talking to them about risk reduction. Anybody, right? But the CDC would tell us that if they're taking over 50 morphine milligram equivalents a day, yes, someone should talk to them about naloxone and they should get access to it. You know what? I think it's a part of our mission as pharmacists to make this happen. The question was, why are doctors not co-prescribing? That is a part of the grant that we're working with, but yes, they should be, and this is what we provide for free at my clinic. You can give this out, 2 vials of naloxone, when you prescribe an opioid at my clinic, and it still isn't happening yet, right? So clearly there's disconnects everywhere. It's not just with pharmacy, it's with primary care providers, family medicine docs, pain specialists, but the more we talk about it, the better I hope it's going to get. But we want to make it easy for people. That's what this is all about. And I'll show you guys more about what's inside here. Can't speak for all cities. St. Louis City, they have access to naloxone. Police officers do. All EMT carry it. And they've been trained. Very good question. Yes, you bet. And naloxone, doing work at several of the shelters in the city, they respond frequently and administer naloxone fairly frequently to folks who have overdosed on the streets. Good question. I don't want you to rack your brain too much on what is 50 morphine milligram equivalents a day. I really don't want you to think too hard about that, because I just want you to think, if they're on a high dose of an opioid, I need to talk to them, right? But I am going to show you how to convert. What's up with number 9? opioid prescription plus smoking, COPD, respiratory illness, renal dysfunction, hepatic dysfunction. So it's all about respiratory diseases and decreased respiration, absolutely. So any kind of respiratory condition is going to impact my breathing if I take an opioid. Also think about HIV and antiretrovirals and how they may impact opioid metabolism. Think about hepatic dysfunction. If I have hepatitis C, that will impact how I metabolize an opioid. So all of those can impact. The other really big one I want you to take note of is what's up with the number 7? Recent release from an opioid treatment program, jail, or hospital. What's up with that one? That's a super high risk category. Yes, their tolerance has changed because they're not using or they're not accustomed to using what they were using, right? Let's not be fooled. People can still use in jail, and it happens. However, it's probably not what they were using out in the community. So we want to be really clear that that is a high risk population. If I go into the hospital for 10 days for pneumonia, and I'm normally using regular opioids in the community and I go back out, you bet I'm a high risk, right? So those are some big ones too. Okay, who should receive naloxone? Let's not beat around the bush, guys. Anyone who walks into your pharmacy and asks for it, right? The person, the mom, the dad, the brother, the sister, they all care or know someone who is at risk. Okay, here's your conversion. We don't have to spend time here. It's in your slides. But just note morphine to hydrocodone, 1-to-1. That's easy. And then note your oxycodone, which is the other one you're probably going to do the most of, 1.5-to-1. Tramadol. So the risk is a lot lower, but people don't just take tramadol by itself, right? So if they're taking tramadol along with several other medications, including an opioid and Seroquel, a more sedative antipsychotic, that increases the risk for sure. Thank you. Okay. So again, unless you've been living under a rock, you know that this is an issue, right? We know that there are plenty of other states in the country that have had increased access to naloxone for a while and the programs work, including Massachusetts and Rhode Island. They were some of the pioneers in terms of access in pharmacies to naloxone. So again, I hate to see the news reports again and again and again, but I love to see what Walgreens had to say today. So hopefully we're going to see more and more things like that. Okay, potential sites for naloxone distribution. Did you know that you can get it at your health clinic? Hopefully, right? Hopefully patients can ask for it and get it too. You can also get it at jail when you're released from jail, and that's part of a program through our STR grant as well. Needle exchange programs, but let's be honest. Are you guys familiar with the needle exchange programs in St. Louis? Yeah, they're very underground and people don't know a lot about them. So that's not very common to get it there. Where would be a common place to get it? Did I lead you right to that? Of course, the pharmacy. Everyone knows how to get to the pharmacy, and you have the knowledge to disseminate to them, right? So absolutely, the community pharmacy is where it's at. That's why we're here. This is interesting. Do you guys remember, did anybody take this survey? Was anybody called or emailed this survey from the Missouri Board of Pharmacy? And so they did get quite a few responses. Some of you may have responded to this. It's really tiny. I'm going to walk closer. And so the one that was curious to me, do you have any naloxone in stock in your pharmacy today? 522 pharmacists said no. That's a bummer. But this was in August. A lot's changed. Yeah, that was before the statewide standing order, right before it. Also, does your pharmacy currently provide training for staff specifically regarding naloxone dispensing? 820 said no, but that's why we're here, right? That's why you're here, and you're going to take this information back to your pharmacy, to your technicians, your interns, right? And I love, though, are you interested in receiving more information? Over 350 people said yes. And so again, I hope you think your job is, when you leave here, take this information with you and disseminate it out in your community. So we're getting to some practical questions. These are some questions that Amy and Nicole and I hear a lot over our time working under this grant. And so we want to address some of these questions. And again, so you can address these when you get back into the pharmacy. I'm uncomfortable talking about an overdose with my patients. What should I say? Legit? Feel legit? Yeah. Okay. Let's talk about it. I want you to share with someone at your table, share with a partner. What are some ways that you might engage someone who's taking an opioid long term? Let's say they've been coming to your pharmacy for years, they've been taking an opioid for quite some time, versus how might you engage someone who's getting a brand new prescription for a pretty high dose of an opioid?
It sounds like it could be easier to present this topic to a newly prescribed opioid.
I would imagine a little bit, yeah. Yep.
So it sounds like it's an easier transition.
Mm-hmm.
And then, I don't know, I was having some trouble coming up with a long-term one, saying, have you ever been concerned about this? I know you've been on this for a while.
Yeah.
Has this ever concerned you or your family members about this product, and maybe trying to work your way in?
Yes, I like a gentle weave in their approach. That's good. Why do you think it's harder to talk to somebody who's been on one for a long time? So that's the fear, right? Is that there's a fear that someone is going to respond in a way of, please don't take this away from me. I need this. I have to have it. Do not talk about something that's going to make it go away, right? So the way you approach this makes a big difference, right? So we're going to approach it maybe with more of, I want to make sure you stay safe. I really care about you. I'm concerned about your safety. Has anybody ever talked to you about safe ways to take an opioid? And you can bet most people are probably going to say no. We have heard so many reports from pharmacists or from pharmacies about that initial frontline exposure and question and how technicians may respond to that, and that can dramatically influence whether or not someone gets it or if they walk away. Right? If someone comes into your pharmacy and asks for naloxone and they can't get it and they walk away, the reality is they could die. Right? They could die, or whoever they're getting it for could die. So we do not want someone to walk away without it, right?
I think I would start a little bit of saying, hey, our pharmacy is recommending, from this medicine that you're on, our pharmacy is recommending that you get some naloxone and have it on hand.
Yes.
And say, especially, you could, if in any way they become offended, say, if somehow you would accidentally take too much, or say, heaven forbid, somebody else in your family got hold of it, a child or something, you would have this on hand.
Oh my gosh, I love that. Yes, I should have given you the mic to say that because that was spot on, right? So let's be really clear, guys. Let's just take my example. I am an almost 40-year-old person with a 5-year-old at home. And if I have oxycodone in my house and my 5-year-old gets a hold of it and she overdoses, you bet I'm going to want Narcan handy to revive that overdose, right? So it's not just about the one person in the house, it's everyone else in the household too. So if you need to utilize that tactic, then go for it. Yes, it doesn't personalize it too much when you do that. I agree. I love that. Okay, good. I'm going to tell you that based on some surveys that were done in Rhode Island and Massachusetts, that these are what we hear from consumers. They are embarrassed to come in and ask for it. And you can imagine so, because guess what? Nobody asks to have an addiction, right? Nobody wants that in their life. They're embarrassed to come ask. Their fear of the consequences, their fear of being labeled as a criminal or being tagged as an addict by the police, right? Or they just don't even know. A lot of people don't even know that they can come in and ask you for it. Oh, look. And if someone comes in and they ask you for it and there's whispering behind the counter between a technician and someone else, they can hear that, right? Absolutely. So please be mindful of words, and if it's not your words, be mindful of the words you hear near you, right? Because they can be really, really hurtful. It takes a lot of courage, guys. And I want to say this a couple times. It takes a lot of courage to come into the pharmacy and ask for naloxone. Imagine what that must be like for that person if they're asking you for it, right? So here's a nice, well-rounded statement. I am recommending that you get naloxone today. The medications you are taking can cause slowed breathing or even death. Naloxone is an antidote. Naloxone is an antidote that you can keep on hand to reverse this. Is it okay if I offer you this today? Now, there's one word that I didn't use in this statement. What is that one word? Good, I like that. I didn't use addict. Abuser. You can use opioid. I didn't, you're right. But you could throw opiate in there. There is an important word I didn't use. Overdose. I did not say overdose. There is data to support that if someone is using or abusing a prescription opioid, the term overdose may deter them from wanting or taking naloxone from you. So I'm purposely avoiding using the word overdose. It's okay if you say it, guys. It's not the end of the world. But know that if you can word it in different ways to make it feel more comfortable, then you may have more success. Now, I'm going to tell you right now, if somebody shoots you down and says, no thanks, whatever, that's okay, you tried. Right? It is okay. I tell every person that takes an opioid about naloxone, and if they get mad at me, I don't really care, right? Because I care about them, and I want them to know that. All right. Other ways to start the conversation, bring these back to folks, because I know this is an uncomfortable thing to think about. I like to practice these. We won't do that tonight in the interest of time, but just pick one that works for you. Would it be okay if I talk to you about some resources? Don't beat around the bush, guys. If someone's injecting or using heroin, don't beat around the bush. Just say, hey, I have some resources, and we're going to show you some in a little bit. Can I offer them to you? Would it be okay if I talk to you about how to stay safe when you take your opioid? So there's lots of different things we can do. Here's some good technician communication ideas. Love this. These are some things you can bring back to your pharmacy. So the blue circles on the bottom, especially talk to technicians and interns about this, right? Because they will be the frontline person that responds when someone asks for naloxone. Or if they're taking a chronic opioid, they may be the first person to address it. Okay, switching gears, we're moving over to Nicole.
Thanks, everybody. My name is Nicole Gaddis. I'm here at St. Louis College of Pharmacy. Okay, so next thing we're going to talk about is which product to dispense for naloxone. And what I want you to point out to you now is the very last page of your handout is a copy of the standing order in Missouri. So if you flip to the back, you'll see that. And one thing that you'll notice is the bottom line in this slide, which is that the standing order only covers 3 products. It covers the intranasal kit that comes with an atomizer, covers the intranasal spray, which is Narcan, and the intramuscular kit. So we're going to go into each of these in a little bit more in depth. It does not cover the last column, which is the auto injector. We'll also go over this today too. Okay, so one at a time. Let's do naloxone intramuscular injection. This is provided with 2 vials as well as the syringes, alcohol pads, and you're going to need to spend maybe a little bit more time explaining how to use this for patients if they've never used a syringe and vial and such, because you'll have to probably take it out, show them that they need to pop off that orange top. They need to insert the rubber needle, pull back on the plunger, inject it directly into the muscle at a 90-degree angle. It can go right through clothes or an overdose. Don't worry about that. But it can be generally a deltoid or thigh muscle. All of these products generally reverse the opioid overdose within 3 to 5 minutes. They might need that second dose. If they haven't responded in 3 to 5 minutes, go ahead and get that other dose ready. Be ready to inject that one as well. One point here is we said earlier this lasts for 30 to 90 minutes, but we're seeing here 3 to 5, right? So the drug might...
If the first dose doesn't work, you need to give a second dose in 3 to 5 minutes.
Exactly. So dose effect, right? So if the first dose is not enough, you need more. But also remember, they still might go back in, especially if they were on that long-acting opioid. The next one is the intranasal, the naloxone intranasal. So this one comes with an atomizer, which is actually not FDA approved, but it is available as an option for a standing order. So don't be tricked by that one. So what you do on this one, it also comes with 2 pre-filled syringes. You pop off that yellow cap, and then you attach the luer lock syringe, twist it, and then basically you do half into one nostril, other half into the other nostril. So this one is a little cheaper than the Narcan, more difficult to use, a little bit more training goes with it, but definitely an option for some of our patients. And then we also, the question is if they are really not breathing a lot, is there a difference in absorption between the intramuscular and the intranasal? There probably is a little bit, but we want the person to take whatever's comfortable for them, whatever product they want to take. So if they're not comfortable like training on the syringe and vial, get them whatever's available and easy for them to use. All the products work, even if they're not breathing. So really just whatever's comfortable and whatever they can afford. That's another consideration too. So the Narcan, if you guys have seen in your practices, the Imitrex nasal spray looks very similar. One of the important things, so this also comes with 2 devices. Very important on this one, there's no priming. It's one it's one and up, one and done. So when they push on that center piece, it's just going to push the whole amount into the nostril. So you want people not to be like, oh, do I prime this? And then they've just wasted their dose right in front of you. So no priming. This one, the brand name is Narcan. So you should dispense the whole box. Yeah, don't separate the box. Yeah, just do one. Just like the other one, 3 to 5 minutes. You might need the other one. I agree with you that it does seem more complicated to inject. What I will say is we've heard from some people that they prefer, like, they're already using needles. They're not scared of needles, right? Yeah. So we've heard that some people are like, I'd rather just have the needle. You have to train the people around you for sure. And
Here, the naloxone, the vials, has been available for over 40 years, and harm reduction initiatives like in Chicago and Seattle have been happening for 25 years, and they've been using the needles. So it's yes, if you're imagining in the middle of an overdose, if I'm terrified, right, it's a lot more steps. But if that's all I can get to that person, I don't care, right? The nasal spray is easier because it's one step, but for a lot of my patients, they don't have insurance, and so they're going to get the vials, and we just do the best you can.
so you actually need to talk to the patient about that in the counseling. So we have slides for that later, but that's okay. When you're dispensing the naloxone, you need to find out, is this for you? And obviously, if they're on the opioid and you're talking to that patient, then yes. But if they come in and are asking for naloxone, I think it's okay to say, are you at risk or is it someone else? Because if it's not you, we need to make sure or if it's you that's at risk, we need to train people around you because they will be the ones using it. So you need to be really clear about that in your counseling session with the patient. The last product is the Evzio, and this product is not covered by the standing order, but it is available by prescription. And this product is very expensive. It is similar to the auto-injector of epinephrine that is available where you pull that white piece out and it starts talking to you. So one thing to note about this one is that there are patient assistance programs available right now. So if you want to go through that process with patients, that is an option if you get a prescription from a physician or if you have a protocol specifically for this one. The current patient assistance program is $0 copay. Okay, so let's get to a little bit more of the dispensing piece. So in Missouri, a bit over a year ago, we were allowed to start dispensing naloxone in our pharmacies with a protocol with a physician. So you had a doc sign protocol saying you could dispense it. So that's been going on for a while. But then, starting August this year, we now can dispense it after running as a prescription using the statewide standing order, which has Dr. Randall Williams, who's the director of the Department of Health and Senior Services. Thank you. Or you can also sell to an individual with documentation as a distribution without running it through as a prescription. Really important point here, Dr. Williams, like we've said, is very passionate about this. He doesn't want any barriers, so you don't have to give a name. Documentation of a name is not required. So if patients want to just purchase this is the way to go through distribution. That's a great question. If you gave me naloxone right now, I'm not on opioids, like nothing would happen to me. So there wouldn't really be any harm that would happen to that patient. They would not recover because something else is going on, but it's not going to be something that causes them to have issues probably. There are a few side effects listed with naloxone. Hypertension's one, especially with Narcan nasal issues topically.
I want to add there's been no cases gone to trial for any healthcare professionals who's ever administered naloxone to a patient or an innocent bystander, right? There's been no cases that have gone to trial. The 911 Good Samaritan law in Missouri covers you if you have drug paraphernalia in your presence or drugs and you call 911, you stay with the person, you will not be charged or there'll be minimal charge for your drug paraphernalia presence. That's what the 911 Good Samaritan law covers that just passed.
Time from overdose till death it really depends how much opioids in the system. Risk factors. I wouldn't say we have a specific time on that. Missouri Medicaid will cover Narcan as well as the first two, right? All of the ones on standing order, they don't cover Evzio, the auto-injector. In order to not give your name, you would have to pay me cash for the product, which might mean you're going to get the vial and syringe because it's much cheaper. So, according to the state standing order, we have a few things that are required to discuss when you give out the naloxone. So these 4 areas are things that we are required to talk with patients about when they come in. So the first one is risk factors. You'd want to just chat with the patient about their specific risk factors, but really most likely everybody's going to have opioid exposure. Personally, there's other important things to talk about. I'm not sure I'd spend a ton of time talking to the patient about the risk factors, right? But you can basically say, because you're on an opioid, that is your risk for overdose. Signs of an overdose, though, are important. So how do you know you're getting there? Very sleepy, lethargic, or maybe unconscious. You're going to start to get blue-gray lips, fingertips, slow breathing. I wouldn't tell the patient, like, count your breaths, but for your information's sake, it's 8 per minute or so. Limp body, maybe some gurgling noises, and those pinpoint pupils. So for patients, what you can say is, are you okay? Are you okay? Try and rouse them, and then try the sternal rub. So everybody try that right now. Take your knuckles, push really hard on your sternum. Does not feel great, right? Push hard. If you have somebody unresponsive, push hard. They should rouse from their slumber. So now you have basically identified that someone is experiencing an overdose. You call 911, right? Just like with CPR. Either you call 911 or have someone else do it. And then you also administer naloxone and place them in the recovery position, which is on their side, their leg on top, their arms crossed over their body, if you can move them. You know, if you can't, get that naloxone in them any way you can. You could do the opposite here, administer naloxone, then call 911. It kind of depends on what the situation exactly is, right? How responsive they are, how well they're breathing, how long is it going to take for 911 to get there. But I will say on your prescription, if you run it through a prescription, the directions have to be consistent with what's on the standing order, which is call 911, and then the directions on the standing order. So make sure you get that correct.
The theory in switching this is that if you come across somebody, or if you're educating somebody and you don't know how, you're saying you've come across somebody, you don't know how long they've been down, and you don't know how close they are to death, that you give the Narcan first or the naloxone first, and then you call 911. If you were with someone and it just happened, you call 911 really quick, get emergency responders on the way, and then administer the naloxone, because you kind of have a better idea of what that timeline is. But again, for the dispensing part, you need to make sure that it follows the standing order just to be in compliance with that. But there's a lot of clinical knowledge that says you kind of look at your situation, and I think if you end up doing it wrong, it's not like one is better than the other, and so people in a panic situation will probably do some form of that. So just call 911 and administer the naloxone, and if it happens in the opposite order, that's okay too.
You might have to perform rescue breathing if they're not breathing at all, or if it's very, very shallow. So you might want to consider offering mouth guards at the same time. Have those available for sale or to give away, because this might be something they need as well. Then we want to have you recommend stay with a person, right? We already heard a lot of times, especially if it's a heroin overdose, that call 911 and they dash because they are afraid they're going to be arrested just, when the EMS gets there. So educate people. There's a Good Samaritan clause. Stay with a person. Help them. They might go back into overdose in a few minutes. You might need a second dose. Go ahead and stay with that person. Also, sometimes patients, when they start coming out of overdose, are very agitated, mad, angry, confused. They might be violent, possibly, so that's good to know. They might be combative, that might occur, so that, get out of the way. Also, they might want more opioids. You just got rid of the high, right? So in that case, you need to be there to be with them. Like, at this point, you need help. You don't need more opioids back in your system. These are good steps for making sure, again, you're talking to the person at risk, but you need to educate others around them about those steps as well. You also need to educate on the use and administration. So again, we're asking the patient, who would use this on you? Who is going to have access to this? Where are you going to store it that they're going to know where to get it from? And when you're doing this, we say avoid using the stigmatizing words we've talked about, addict, user, abuser, overdose, but instead think about he is addicted, she used drugs, the patient has an opioid use disorder. You might consider talking to them about these other things. It almost depends on how much time you have and how important they are depending on the conversation. But expiration date, adverse effects, maybe strategies to prevent overdose, those kind of things. Talk about your role in what you think you might do versus the technician roles that you work with. Did you guys talk about anything?
Well, Yes, we did. We were talking about when we get home, we've got our pharmacists, 2 or 3 of them are already trained on naloxone, and they've been using a lot of it in our pharmacy. So that the technicians, it comes as a prescription though. So we want to train everybody in the pharmacy what to do when someone comes in and asks for it, because most of ours have been by prescription. So we want to be sure that the technician, when somebody asks them about it, says, oh, let me get the pharmacist over here, very, not a shocked look or like, yells it out and just understands, hey, they want to talk, that's what we were talking about.
That's great. As part of the grant, we've had public people call in and tell us about their stories. And we've heard that. Like, hey, Bill, they want that drug, that naloxone for that heroin. So we definitely have to take these back to your technicians. And we are happy to give you resources and slides or whatever you want to take back to help the techs out as well. So, here we go. So the other things we've heard on the grant is, I think that we have that, but you need a prescription, even if we knew at the time that pharmacy had a protocol. Are you sure you want that? It's really expensive. I have no idea what you're even talking about. And we did hear this. A patient called us because they called the pharmacy and someone, I don't know if it was tech or pharmacist, said, yeah, you can get that, but it's like a flu shot, so come in and I'll give it to you. Another person on the phone said, are you overdosing? I can only give it to you if you're overdosing. Well, I'm on the phone right now. Can you put it through the phone? So this is just re-emphasizing that there's a lot of unknowns out there, and these are even in pharmacies that we knew have protocols already, so please take this information back. Please share with your pharmacists, share with your technicians the right information about naloxone. So let's fit it into a workflow in a community pharmacy. If you identified, or your technician may even identify a potential person for naloxone, you might want to start with, are you willing to put this through your insurance? Because if they want it to go through their insurance, they're going to have to give you a name and have it go through prescription processing so the technician can do that prescription processing. If they don't want a name associated with it, then it's that distribution piece, right? And then you have to do the documentation piece, but you don't need a name. So to be specific, if you're going to document for distribution, so by invoice or sales record, you have to document the transaction date, product name, strength, and dosage form, the quantity, plus or minus the patient name. You have to keep that for 2 years. So those of us that are a little older might remember doing something similar with codeine cough syrup a while back. Right? If you're going to run it through as a prescription, you fill the prescription with Dr. Randall Williams as the physician. His information's on that standing order for you. The refills are PRN. The SIG codes are on the standing order. Products are on the standing order. Okay, so continuing on with workflow, if you're going to do this standing order, run it through as prescription. The technician can do all this, so make sure you're training them on this. If you're dispensing, the Missouri Board of Pharmacy actually in their handout that all of you probably received in the mail as well as online has the guide regarding the standing order. They did recommend to document the patient's name, but please remember, you don't have to, and they say you don't have to. But it is written here, so I want to make sure I acknowledge that it's written in there. But it's not a requirement. They do recommend that you make sure on the label has the expiration date and lot number, which is going to have, if you're going to give them the box, you don't really have to worry about that extra labeling stuff. Technician can prep the product, pharmacist educates, technician can sell the product. So let's talk a little bit about payment, always a big question. Each insurance company is different and contains different billing requirements. Importantly, you need to know MoHealthNet or Missouri Medicaid will pay for naloxone for eligible enrollees. The Board of Pharmacy stated they can't give you information about insurance. We tried to talk to the Department of Insurance about it. They also said it just depends on the patient's plan. But what you can do is you can run it through, and if it goes through, then it's going to pay for that person. Generally, most pharmacies are going to run it through for the person standing in front of them. So if that's a mom whose son is at risk for overdose, you can still run it through for the mom. And the insurance can decide if it's going to pay or not. It's going to depend on the insurance if there's a quantity limit. Yeah, currently Missouri Medicaid has no limit. So if you're looking at cash pay, Evzio's ridiculous if you're going to pay cash. Narcan, about 150-ish. The vial and also the atomizer are much less than that. So their cash pay, you might want to think about, do we need to get them the vial? If your patient has trouble paying, in St. Louis particularly, we have a lot of options for them. You can send them down NCADA. You see the addresses here, so you can refer patients for the free supply at those locations while it's available through the grant and through MoHope. So, yes, it's going to take some training for your staff, your pharmacy, but really it doesn't take that much longer than a normal prescription with a little bit extra counseling probably. And if these are available for download on our website, so if you need a cheat sheet to remember those 4 things you have to go over with your patients, then this is a nice thing you can walk through. There's 2 of them because one's the nasal spray and one's the intramuscular injection. So we're hoping you guys can see that just with a little bit of education training tonight, that you can go back, put this into your workflow to help save those lives, right? To be the hero for these folks. So let's do some FAQs. Just yell out yes or no. Do I need to notify the board, DHSS or BNDD, that I'm going to dispense naloxone? No. Do I need a prescription to dispense under the standing order? Nope. Is there an age limit on the standing order? Nope. Is there a refill limit on the standing order? Can I dispense FZO under the standing order? No. Do I have to create a prescription? No. Nope. Is training about naloxone required? No. It's not. Training's not required. It's recommended for pharmacists. You know, they can pick up this information, read it. There's no training that is required. Can I dispense to an entity like a school? No. Okay, so all these are no. So what I will say, I'll add a couple things here. The standing order, the way it's written, is meant to dispense to a person. So if the principal wants to come down and get his naloxone, he can do whatever he wants with it. He can take it back to the school and have it at his school. But I have to dispense it to the principal. I can't dispense it to the school. Okay, just that's how it works legally. But I will say, Dr. Williams is extremely passionate. I'll say it again. He does not want barriers. He wants people in the community to have access to naloxone. So we tried to make it as easy as possible, as clear as possible, to get it out to the patients. He was emphasizing the other day that, no, there's no age limit. Got a 16-year-old at risk? Give it to him.
Okay, we're closing out, guys. We're at the end. I wanted to jump back in here to talk about risk compensation because this came up at the very beginning. Someone brought this up, right? Does naloxone really work? We know it does, right? We know it reverses the overdose, but wouldn't some people just use more? Wouldn't they just use more heroin because they have this thing that's going to save them at home? Risk compensation. People believe this. People believe this to be true. This is a huge barrier, right? So I want to tell you, if you are not one of the believers of this, you don't have to tell us if you are, but if you are not one of the believers, I want to give you some advice on how to address this. This idea of risk compensation, there's no hard data to support this, first of all. There's no hard data to say that someone who uses heroin uses more because they have naloxone. In fact, easier access to naloxone decreases emergency room visits and decreases overdose deaths. So some things that you can compare it to are, do you wear a seatbelt? You don't have to raise your hand, but most people wear their seatbelts because it's the law, right? Just because I wear a seatbelt doesn't mean I drive faster. Now, there are some people who are risk takers. Maybe they do drive faster because they have a seatbelt on, but most people don't, right? I love that comparator. Do you have a fire extinguisher in your house? I would venture to say most of you do, if not all of you do. Do you have it there because you want your house to burn down or because you want your house to catch on fire? Absolutely not. You have it there just in case an accident happens, right? Harm reduction. Just to understand the concepts of harm reduction, and no matter how you explain it, guys, you can use any of these examples. You can use condoms, you can use needle and syringe access. All of these programs work. You can talk about HPV and vaccines. No matter what you do, just making that statement of someone is not going to use more because they have access to something that could save their life. What are your thoughts on that? What are your thoughts on risk compensation?
Well, even if they do, still, you can't control that.
That's right. That's right. Yeah. And I have heard people say, well, I've seen somebody get Narcan 3 times and they've overdosed 3 times. I mean, come on, how many times do we do this? And do you know what I say back? As many times as it takes for them to get it. Yes, there you go. There's another good one. The plan B argument, right? Yeah, that's right. You know what? Addiction and recovery is challenging. And so, you know what? If it takes somebody 5 times to get it, then it takes somebody 5 times. And they're still alive and they're still with us to tell their story. Okay, so harm reduction in the community. I really like to I really like to promote at least access to clean needles. It's really, really important that people have access. Some of the stories that you will hear from people who are actively using and what they do to get needles is disturbing. So just imagine decreasing the exposure to hepatitis C, HIV. It's just really, really important. We don't need to dive into the prescription drug monitoring programming, right? We're in Missouri. But that is a form of harm reduction that we can utilize in a good way. What else can we do? We can talk to people about how to safely take an opioid. There's lots of opportunity to market yourself out there as a safe place to talk about opioids or to talk about safe harm reduction initiatives. If I have intrigued you at all with the concept of harm reduction, I would encourage you to check this out further because it is a pretty phenomenal phenomenon that we've practiced in substance use for a long time. Okay, so let's go through these really quick. Naloxone is a competitive antagonist at opioid receptor sites. True or false? Is it going to turn green? Yeah. It reverses the analgesic, dysphoric, and other pharmacological effects of opioids. Yes, but what do we care about? We care that it's reversing their respiratory depression, right? It's effective in reversing an overdose with benzos, barbiturates, or stimulants. Absolutely not. It has been FDA approved and used by EMS for over 40 years. Very true. It's a shame that drug companies have taken advantage of new products. My own personal thoughts. It is the same thing as naltrexone, a long-acting opioid antagonist. It is not the same, but you are going to hear a lot of people that think it is. So make sure you dispel that myth. It's not the same thing. Naltrexone is often used for alcohol use disorder. It has minimal interaction in the body without the presence of opioids. True. In fact, if you were to give it, again, like the example Nicole made, if you were to give it to someone, they haven't had opioids in the last 72 hours, virtually nothing will happen to them. Okay, so don't worry about hurting someone. All right, these are some links, and then we're going to close it out. I want to be really clear, guys, because we've covered so much information. How could you keep it all in your brain? You don't have to, because there are so many resources out there right now that you could Google. Number one, you can go to the Missouri Board of Pharmacy website, and you're going to see naloxone all over the place, right? Prescribe to Prevent is one of the best resources that I've been able to find. There's pieces on there for the pharmacist, for the patient, for the physician. There's videos, there's all kinds of fun stuff. Prevent to Protect is actually a derivative of that just for pharmacists, which is really cool. There's lots of stuff out there on safe prescribing. And finally, but not the least important, the most important, if you are thinking, I don't know what I would do if someone did confront and say they had an addiction, I wouldn't know where to send them. The Substance Use Treatment Locator through SAMHSA allows you to go to that website, put in your address or their address or zip code, and it tells you all the treatment facilities in their area. So at a minimum, you can offer them that. I even encourage people to have cards nearby in their pharmacy, kind of like the suicide prevention cards, where they can either have that phone number or that website on them. So people can walk away with that. And at a minimum, you've brought that thought into their head.
Do you guys remember your 2 barriers that you kind of thought about at the beginning? Were there any that we didn't address? Because we've talked about a lot. Yes, there are genetic components where people... Yeah. We do know about 80% of people who are taking heroin started with prescription opiates. So there's a pretty clear link there. So in order to give naloxone to a patient, which one of these is correct? 3. Yes, 3 is the correct answer. So number 3, so you do not need a prescription to process. Remember, you can do it as a distribution, so you don't need the prescription. Missouri did not declare it an OTC drug, and there is no age limit. True or false? True. Right. Which is why, again, we have those materials available so that those can be handed out every time you educate a patient. You can send them away with written material that covers all of those items that need to be covered as part of the standing order. Hold up fingers again, 1, 2, 3, or 4, which is not a risk factor for opioid overdose. Number 1, So amitriptyline with tramadol is not a risk factor. Alprazolam, so a benzo with an opioid, history of overdose is always a risk factor, regardless of any other factors. And then use of chronic buprenorphine as an opioid for non-cancer related pain. Okay? All right, which of the following medication describes an appropriate use of an available delivery system? Number 3, right? So if you're having a test, you don't know the answer, guess C, third one. So right, the first one, you don't do it if you're dizzy. That's not really one of those symptoms of an overdose. You don't self-administer any of these, so number 2 would be incorrect. You can, and there might be some confusion there, right? Because if you have an EpiPen, you might self-administer an EpiPen, but not the Evzio. The Narcan, somebody else administers, and Evzio, again, is the injection, the auto-injector, not the nasal spray. This one, 4, correct. And if there's specific resources that you want, we could also send those out. Again, we're putting all those available on the MoSTR website and available for free. Thank you, everybody. Have a great evening.
To find our resources, head to MissouriOpioidSTR.org. You can click right here on Resources to get to the page that has most of our PDFs as well as this webinar. So you can download these to hand out to patients, to use for yourself, and we have color and black and white options. If there's something you wish you had but isn't here, please contact us and we'd be happy to develop something. Thanks for attending.